Okay, there I am. There was a good deal of talk today, appropriately on this panel, about the need to integrate treatment into dealing with offenders who are addicted to whether it be alcohol or other substances. And one of the problems we have in the U.S. is we don't have places, maybe Mark will correct me, but I don't think we have places, enough facilities to accommodate the needs generated by identifying these people who clearly do have addictive problems. Now, we've been trying to undergo some changes in our healthcare system recently in the U.S., and we're making some progress, and we'll see if we can maintain it. But in your countries, do you have the resources to do what you say isn't needed? I agree that it's needed, but do you have the capacity, the beds, to put people into the appropriate treatment that'll help them really deal with their problem in the long term?
That's all. I think that's probably a commonality between all of us. I think most of us would say we don't have the capacity to ever meet the demand that's actually out there. I think there are some interesting examples currently in New Zealand, and there's some other examples elsewhere in the world where we need to triage offenders. And we have assessment and referral services. For example, we're doing one here in Wellington where A&D counsellors assess offenders in the community to try and stop treatment system blockage. I think that's really important. And I guess that was also part of what I was trying to say in my presentation. There are some clients are going to need to go to treatment straight away. And then there'll be some clients who maybe aren't at that point of change, that actually a more offending behaviour intervention might be more appropriate at this time, and then they may later go to treatment. But I think there's always, I think most of us here in the room coming from a treatment background will say there's not enough places for those who need them.
I think that's true. I mean, it's certainly true in Australia. But my sales pitch to government would be that it's still cheaper to put someone into a treatment facility than it is to put them into a jail. And therefore this might be a more sensible investment because it's something of a joke to think that putting people in jail is going to seriously change their drug use behaviour per se. What in fact happens is that they may in fact end up in riskier drug use, and the unforeseen consequences may actually be worse. So I'd rather see some money diverted from building prisons or running prison beds and see it used in a more therapeutic sense.
So I guess that's my cue. It seems to me perverse when there are more people seeking treatment than we have capacity for, to use that scarce capacity on people who don't want it and will run away from it. One good way to economize on treatment capacity is to not treat people who don't actually need treatment. And what we've seen in both 24/7 and HOPE and its related programs is the very large number of people who present in the criminal justice system looking as if they have serious dependency problems can and do quit simply by being told you're being drug tested regularly, and every time you're positive you're going to spend a couple days in jail. The people who failed 3 times have now selected themselves as actually being in need of treatment. Angela Hawken calls this behavioral triage. In a typical criminal justice population, it's no more than 15% of those who present originally to the system. So it seems to me the rational thing to do is to use a desistance mandate up front and a treatment mandate on those who fail to desist when ordered to do so and given immediate consequences. The notion that punishment doesn't work is true, and punishment is done badly. But if the criminal justice system can learn the skills of a good parent, lots of people can and do get better without formal laying on of hands.
In my experience, there are many people who are addicted who resist treatment. They aren't going for treatment. And this is an opportunity in this system to the coercive treatment. I mean, lots of experience with people who desperately need treatment, but they won't acknowledge it, and they won't And in our system, they can get out of a program after 3 days or something like that if they want to.
So let me just respond to that. It turns out when the judge sends you to jail for 2 days every time you test positive, and having done that 3 times in a row says, okay, would you like residential treatment or a prison cell? The number of people who resist treatment goes down quite a lot. And then they show up in treatment actually wanting to succeed, not saying to the treatment provider, well, the judge told me I had to be here, now do what you like with me. So if you talk to actual treatment providers on Oahu, they love the program. It brings them clients for whom denial is no longer an issue, and where the therapeutic alliance has been created by the judge.
Yeah,
Mark,
I
it's
sell
time
that
for
to
us to
my
leave the
patients
room.
as reality therapy.
And I think that also links into something that I was trying to say. I think also as treatment providers, we need to get better at motivating and realising that entry into treatment and programs is part of the treatment, and that people don't necessarily always have this kind of sudden kind of awakening that part of treatment is to do that. And I think that's why I think around drug-impaired drivers programs, those kind of interventions, we've got to be quite clear what it is that we're actually doing. That just a bit of education isn't actually going to bring a behaviour change. We've got to really structure it around what we know works in delivering behaviour change, and also working with offending behaviour.
On behaviour change, Rachel, I thought your ads were fantastic and quite amusing, and it struck me with the chuckles that we got from the audience, whether the target audience might also find it amusing. And was there any evaluation of whether it was actually deterring people from drug driving?
Well, as I mentioned, we're not actually at that point. We're just simply at a point of trying to get the issue on the table and get people to kind of, to chip away at their current comfort and belief that they're okay to drive. Everything that we produce is tested with the specific target audience before we ever produce it, so at concept stage, and then again at post-production stage before it ever goes on air. And then we evaluate rigorously afterwards, day to day, literally 364 probably days of the year, with the target audience through an independent research company to ensure that the correct message is being taken out, that our target intended audience is actually receiving the message, that they've seen the message, that it's relevant for them, that it's got watchability, that they talk about it. We do ask if it's likely to change their attitude. Obviously that's self-reported. It's a big qualitative one-on-one test. So yes, we do a lot of that. It's doing its job so far, but as I say, it's in the very early stages of a long-term behavioural change campaign, so we're literally just wanting them to see and hear and talk about the message.
Hi, I actually have a comment and a question for you guys. Edward, I was really impressed with your talk, and especially about the therapeutic part and needing long-term treatment. There are a couple of issues around that in the services that I work with, that the big push these days is for short treatment stints, not long-term treatment. It's kind of like getting people out, hurry up, get them fixed and get them back out there. And that doesn't really fit in that therapeutic kind of alliance very well. And the other issue is with the justice system in terms of getting people into a treatment facility if they have a conviction, that there's a lot of treatment facilities that actually won't take them. And there's issues around, they're going to be, it's going to be detrimental to other people in the treatment facilities. So these are real big challenges that we face at this time in New Zealand.
My first comment would be that brief interventions work. I don't think we should ever throw out the idea of brief intervention. I think Mark's point is well taken. There's a group of people who, given the opportunity to stop their drug use, can do that relatively simply. That's not the dependent group. It's a rainbow, and clearly at one end of the spectrum you've got people for whom drug use is occasional, voluntary, and it's relatively easy for them to stop. At the other end, you've got people who become really sick if you stop them using, whether it's alcohol or other drugs. So there's not going to be a one-size-fits-all, and there's no question, there's a really good evidence base that brief interventions work, whether they're done in the doctor's surgery, whether it's something that's done in a police station. I mean, for heaven's sake, the vast majority of people who are picked up for shoplifting and getting a shoplifting warning notice are never heard of again. You know, the vast majority of kids who go through the children's court once are never seen again. We all tend to get preoccupied with the people in the revolving door. And that is a different group, but that doesn't mean the brief interventions aren't worth doing and trying for the right group. And I think that Mark's point made earlier is a really valid one. How do you select the people where you want to make the investment of time and energy? Your point about prejudice, about people who've got a prior conviction, is just that, it's prejudice. I mean, it's no different to prejudice on the basis of race or religion. This just happened. What do we know about the difference between people who've been convicted and people who haven't? Certainly if you're looking at the juvenile delinquent group, the difference is how often they've done whatever it is and how serious it is. There are lots of studies that show that most kids have done something at some stage in their life for which they could have been arrested. The difference is that they do it more often and usually do worse things. So we need to get away from those prejudices and treat people as people.
I think just to add on that, you know, there undoubtedly are some people who self-change, you know, and we need to look at that. We need to look at what we can. Most people don't need our help, but there are people who do need our help, and those people who do need our help, I think we need to. That's a bit of a kind of a phrase, but it's a bit tricky. You know, we're all trying to work out how you do it, but match the intervention to need. So those people who have long histories of dependence, so-called previous treatment failures, complexity of issues, need a higher level of support, should be going into one type of treatment, and those who don't should be going into a different sort. So it's about a treatment continuum. And I think, you know, we have to be real. Fiscally, things are tight, so it's like, how can we do more with what we've got? How can we be more creative? And I think that's the challenge for the treatment system is, you know, how can we do that? How can we extend treatment, extend supports? I mean, I just echo the comments around the criminal justice and the convictions. You know, all a criminal record tells you is what someone's actually been caught for. And I used to work 25 years ago with lifers in an English jail who needed a rehab for their parole, and no rehab would give them a place because they'd been done for life and murder. Or they weren't motivated. You know, they need to be out in the community for a month before they can come into our rehab. And it's like, it doesn't work like that, you know. And actually, a conviction means you know about something.
Oh, Kerry over here.
One of the, I guess it's one of the questions I have is around focus and messaging and focus. So one of the challenges we get in a road safety sense is the way the media pick up on things is if it bleeds, it leads. So what makes the front page of the paper is the dramatic crash, the really stoned driver who falls out of the car, the tourist crashes and so forth. And what that does is it masks the wide behaviours that the rest of the motoring public do. So we end up with a small number of individuals at very high individual levels of risk. We end up with a really big bubble of people with a high collective risk, but individually it's nothing. One of the challenges that I see is where do we aim the best effort? Do we get the best gains at trying to target the people on the right of the curve who are our recidivists who are going to make the front page of the paper? Or do we get far bigger gains in the system by targeting the casual user who's going to enter into the system? And I'm just throwing it out to the floor if there's any views on, you know, are we best dealing with the left of the curve, the people coming into the system, or do we spend a whole lot of effort with the people on the right?
It's probably going to be different for who you're talking to, isn't it? From an advertising perspective, and you can talk to this too, Simon, I'm sure, but from an advertising perspective, we're not going to make any traction with the recidivists, with the hardcore drug users. We're only going to have effect on those that, with the help of enforcement and with the incentive of enforcement and the stick, can see the benefit in changing. And it's long term again, so over time we can only affect that change. But with regards to the recidivists, there's nothing that we can do in any of our advertising work across any of our road safety issues that will change their behaviour.
And I think I'd just add that I mean, this is a challenge for public health and social marketing that is real. And if we get it right in our planning, we'll identify that. And I'm not sure if we've got that right for drug driving. I mean, we're new. This is a new space. I think we've identified a target audience for the Steer Clear program that's large. It's more likely to be those that are not at that end of the scale, as Victoria was saying, I think. One of the things, though, in different behaviour change I've worked in, for example, around sexual health, we would often focus on a very small number of people. We're dealing with an infectious disease. So actually, and we're interested in infection, and we understand how the infection works, and if we get a small number of people who may be responsible for quite a large number of the infections, that could be a really good strategy. So I guess that's just a way of illustrating that it really is down to that good planning stage and really thinking about what do we know about how this audience works. Our experience, similar to what was just said around cannabis users, is if you like, I think we deal in the religious users, it's unlikely we're going to persuade them. And actually we can get some better traction by persuading a far larger number of young people who don't occupy that space.
Part of the complexity is that we're talking about an increase in a relatively small risk. If every single drunken driver crashed the car, no one would ever drink drive. If every single person that ever took drugs had a crash every single time, you'd have to be an idiot to get in the car after using. The reality is the vast majority of drunken trips are completed. Yeah. The vast majority of drug-affected trips are completed. So we're trying to convince people of a substantial increase, but in a very small risk. And it's very hard for people to get their head around, which is why if you go back to Ross Hommel's work in the 80s, looking at the introduction of random breath testing, what he talked about was raising the perception of the risk of being caught in order to change people's behaviour and maybe over a generation change the value that they place on road safety. And I think it's that process we've got to get ourselves involved in. You can't, with any one step, whether it's advertising or enforcement or punishment or treatment, change the face of the problem. It's a very complex problem, and we're talking about relatively low risk. You know, my parents used to have cocktail parties, and people would ring up the next day and say, "Was I at your place last night, young fella? I don't know how I got home." So obviously, the vast majority of those trips were completed, but they were obviously impaired.
I'll just go back a few years, talking about drinking and driving. There was an effort made to try and get at those repeat offenders. The person who drove after drinking repeatedly may have been caught several times, trying to understand what made them tick and what we could do to get through to them, to get them to change their behavior. It may have been naive, but it was really, really interesting what they did, because they did the usual focus group approach where they talked to these guys and asked them what would make you stop, and they came up with a series of messages that were really rather creative but got very little airplay. And they decided that this group was certainly older, takes you a while to accumulate a few charges, but the questions that they essentially posed to these guys in the commercial that they did was, if you go to jail because of your drinking and driving, who's patting your dog? Who's raising your kids? Who's sleeping with your wife? That's the kind of thing that got through to them. That's not the kind of message you're going to use with kids. Now, I don't know how that translates to repeat drug drivers, but it's an example of the kind of focusing you need for certain groups. And the idea that you can put a message out for a particular group, a very, very small group, really, relative to the vast population, I guess just was not economically feasible to continue that. It got very, very little play.